Hello, everyone. I'm Master Miles. I'm the Health Equity Program Analyst for HealthBegins. And again, welcome to our second statewide session on understanding CBO implications pertaining to the updated DHCS guideline on community supports. Again, we're just waiting for a few more people to come in and we will get started. I just want to say, can you advance the next slide, Visem, please? I just want to let everyone know that this will be recorded. So you will get a message on your screen saying that this is recording. Just wanted to inform you of that. And again, letting a few more people come in and we'll get started in the next minute or so. Perfect. Okay. And we will get started. Do you mind advancing to the next slide, Visem, please? Perfect. And so again, hello everyone, I'm Master Miles. I'm the Health Equity Program Analyst here at HealthBegins. And I would just like to start by saying hello and welcome to our, again, second statewide session. I would like to say that we are partnered by HealthBegins and Aurrera Health Group, and we are also funded by California Healthcare Foundation, in which they're dedicated to advancing meaningful and measurable improvements in the way healthcare delivery systems are provided to people in California, particularly those in low income. And I would also like to say that we do have our funder on the line, which is our program officer, Carlina Hansen. Do you mind advancing to the next slide for me, Visem? And I would like to pass the mic to her to give us a few words. Carlina?
Nasser, can you see me?
Yes, I can.
Okay, great. Thank you so much. Greetings, everybody. Thank you so much for joining us today. Before I turn it back to HealthBegins, Nassera, I wanted to share just a little bit about the Healthcare Foundation and why we're engaged in this work, supporting partnerships between managed care plans and CBOs. I think many of you are familiar with the foundation. Just briefly, California Healthcare Foundation is a healthcare philanthropy based out of Oakland and Sacramento. As Nassera said, we are dedicated to advancing meaningful, measurable improvements in the way the healthcare delivery system provides care to the people of California, particularly those with low incomes and those whose needs are not well served by the status quo. Over the past couple of years, we recognize the state started to manifest its vision for CalAIM and the future of Medi-Cal. Community-based organizations were going to play a really critical role. And yet we were hearing from so many people that they needed support to make that vision a reality. So this work that we're doing with HealthBegins is designed to respond to that need. We're incredibly grateful to be with you all on this journey, which, as I think we all know, when it comes down to it, is really about health system transformation and a shared commitment to health equity. The session today on understanding CBO implications pertaining to updated DHCS guidance on community supports, that's a mouthful, is part of a broader portfolio of work at CHCF that is designed to provide TA and support to CBOs in the context of CalAIM. So a big thanks to HealthBegins, Rishi, Nassera, and the rest of their team for sharing their expertise with us today. And thank you all for joining. With that, I will turn it back to Nassera.
Thank you so much, Carlina, for that. And Visem, can you advance to the next slide? Thank you so much. And so today for our agenda, we'll be going over session expectations, program background and objectives, key DHCS guidance updates, and the next steps. And can you advance the slide, please? And so for session expectations, can you advance the slide? Thank you so much. For session expectations, we ask that each CBO complete a post-session evaluation survey within 24 hours of today's session, in which will be sent out after this. And also complete a post-program evaluation survey, in which you will receive in the next few weeks. And other expectations we do have, our CBOs will be able to review resources on the HealthBegins website, along with view this presentation, in which I have posted in the chat for you all to see. CBOs also will be able to answer specific questions, and we're encouraging you to contact MCPs directly. They'll also be able to respond to your questions, Along with TA partners will respond to CBOs questions and direct CBOs to resources where possible, along with we have the resources in the presentation as well. And can you advance the next slide, please, Ms. N? Thank you. And so we'll go over the session background and objectives. Next slide, please. And so for the objectives for this session, we plan to have you guys be able to describe the implications of DHCS updates guidance on billing and invoicing between community support providers and MCPs and CBOs, along with describe the implications of DHCS updated guidance on member level information sharing between MCPs and ECM providers for CBOs. And with that, I would also like to pass it to my colleague and the founder and CEO of HealthBegins, Rishi Manchanda, to go over the background.
Nasra, thank you so much, and thanks to everybody for joining us. We're moving at a good clip here, so I'll just pause for a moment to orient everybody and build on what Nasra and Carolina shared. I'll also ask everybody in joining me and sending our best wishes to our colleague Alexis Taylor, who's also on our team, but who had a family emergency. So I want to thank Alexis as well as Nasra for their work on this great project. We wanted to just orient everybody to why we are doing this session and what we've been doing for the past several months at HealthBegins. With our partners at Aurrera Health and with other implementation partners like Transform Health and others, we have been working to support the promise of CalAIM, which of course is trying to improve services and outcomes for Medi-Cal beneficiaries statewide. What we recognized well over a year ago is that to do that, to realize that vision, we needed a new approach to developing both near-term and longer-term infrastructure, the technical assistance infrastructure for community-based organization or CBO and MCP or managed care plan partnerships, specifically Medi-Cal managed care plan partnerships. We really believe that this work, the partnership development work, should be grounded with a view to equity, in particular, looking at structural inequities that have often prohibited CBOs, for example, CBOs that serve rural communities or CBOs that serve BIPOC communities and CBOs that have traditionally not had a history of working with managed care plans. We wanted to make sure that with an equity orientation, we're able to provide the technical assistance to space for seekers of technical assistance and providers of technical assistance, particularly plans, could come together. And so as you can see on the right, we have been coordinating technical assistance sessions in 4 counties over the past several months in San Joaquin, Shasta, and Sonoma, and Stanislaus. In those specific counties, we've been working with plan partners, Partnership Health Plan of California, HealthNet, and Health Plan of San Joaquin. And in those regional county-based sessions, CBOs that had been identified or self-identified or been recruited to join these county-specific sessions have come in to learn about what it means to contract with Medi-Cal managed care plans to be able to support CalAIM. This statewide session is really in furtherance of the effort, the concurrent effort that we have, the initiative to make sure that at the very least, every CBO, whether you're interested in providing community supports under CalAIM or potentially enhanced care management, otherwise known as ECM, regardless of your interests, if you do have the potential to provide value to Medi-Cal beneficiaries in the state, because you can support either enhanced care management or provide community support services, like housing, medically tailored meals, asthma remediation, et cetera. We're hoping this is an additional session for you, in particular, to give you some orientation to some updated guidance that came in from DHCS. So we can go to the next slide, please. The value proposition for both today's session and this whole effort, which is what we call the CalAIM Medi-Cal CBO Partnership Network, really are twofold. There's value propositions for community-based organizations, we hope, and also value propositions for the plans that have been participating with us, particularly in those county-specific sessions. We're hoping that at a high level through these sessions, that community-based organizations here on the left, we can go back one, please. Thanks. We're hoping that CBOs that are, as you can see on the left, that participate in these sessions are better able to describe some of the essential components of the CalAIM and related contracting information. That's what we're going to touch on today. Assess their own strengths and readiness to be able to engage in partnerships, whether it's through direct partnerships with plans or even partnering with plans via intermediaries. there are a variety of different ways that we hope CBOs that participate in these sessions are better able to assess their strengths and improve their readiness to be able to engage in those kinds of partnerships. On the plan side, on the right, you'll see that the value proposition for this work is to support the staff and managers in Medi-Cal managed care plans across the state, and those participating in particular in these county sessions we've been running. We're hoping that this at least saves time for them as they seek to meet the requirements for CalAIM that the plans have to meet. And in doing so, also are able to address a broader number of community-based organizations that have the potential to provide value to plan members, Medi-Cal members. There's a strong interest we've seen in talking with several plans about using these opportunities, these technical assistance sessions, especially again in the county level, as well as these statewide ones, to be able to support more and more CBOs to move further along the readiness spectrum. Again, that supports the plan's interest in being able to expand their community support provider network or their ECM, enhanced care management provider network. So the point is that there are value propositions we hope for both CBOs and for plans in the nature of this network and the kind of sessions we're doing. And that's exactly what we want to be able to provide today for all of you who are joining us. Before we proceed, I wanted just to get oriented for who's on the line. So my team will start by modeling this, and we'll make sure that everybody hopefully can have a turn in the chat. If you want to provide your name, please, your organization affiliation. So your name, your organization affiliation, and also your location, or at least the locations that you serve, city or county in California, that'd be ideal. So again, if you can put your name, your organization affiliation, and location into the chat, I think that'll get everybody oriented to whoever it is. And you can use the chat to answer to everyone. Thank you. So with that, I think go to the next slide here and allow Nasra to launch a couple of polls so we can get a better sense of where you're all at. Thank you again.
Thank you so much, Rishi, and I will get on to our polls. And so for our first poll, let me launch that for you all. 1 second. So for our first poll, we have, how far along are you in the CalAIM community supports contracting process with an MCP? And so we have a variety of answers, and I know that we have a whole bunch of people in the room. And so we just want to gauge where you guys are at to see who, again, we have in the room, as Rishi had stated before. And I'll leave this poll on for a few just so I can see. And so far from what it's looking like, at least as you guys can see, we are interested in contracting but have not yet started. And that's what we're looking at right now. And so it's giving a broad spectrum for now. I'll give it maybe 2 more seconds. And so again, like I said, we have right now, we are interested in contracting, but have not yet started. And close second, we have just starting conversations with MCPs, which is great to hear. Perfect. I'm gonna end this poll and share the results with you all. And as you can see, like I had said, we have in the lead, we are interested in contracting, but have not yet started. And then in a second, we have just starting conversations with MCPs. And from our previous sessions, this is actually interesting, just a small evaluation. We have a lot more CBOs that are just starting. And so that's good to know where you guys are at in the process. And Bassem, do you mind advancing to the next slide so I can launch the second poll? Perfect, thank you so much. And for our second poll, we have, as a CBO, what are your foremost infrastructure and capacity concerns as you move past the contracting process and begin refining programming, workflows, and processes? And what challenges are you anticipating? And again, we have the options of not sure yet, haven't moved past contracting, staffing and our service capacity, assessing housing, subsidies under ECM and community supports, data sharing challenges, infrastructure training to staff, reviewing existing systems, coordination with other local providers, billing, invoicing, securing NPI. And if you have any other ones, please make sure to share them in the chat so we can talk about them in the Q&A. And I will also leave this up a little bit longer so you guys can answer and we can get some good. And so right now,
this is Carlina. Just a quick thing for those that don't know, NPI is a National Provider Identification Number, because I know we got some feedback in the Q&A that there's a lot of technical language being thrown around. So just want to make sure that some of the acronyms are a little bit easier to understand. And ECM and CS enhanced care management and community supports, which are a part of CalAIM. And please, if you have other questions or things that aren't clear, feel free to put them in the Q&A or chat.
Thank you so much for that, Carlina. I do want to add that we do also have some informational stuff in the slide deck link that I provided, and it does go over the acronyms as well at the end of the presentation. So again, thank you for that, Carlina. And I'll leave this up just a little bit longer. And again, so far, like we had seen in the last poll, we have not sure yet, haven't moved past contracting in the lead. And then in second, we have some people who are actually in billing and invoicing. And with a close third, we do have data sharing challenges. And so I'll leave it up for maybe 5 more seconds. Okay, let me end this and share the results with you all. And like I said, as we can see, and from the last poll, we can see that we have more so newly entering CBOs in this space, and where they aren't sure and they're moving, they haven't moved past contracting, again in the second, billing and invoicing. And so we're seeing a very big divide, which is great. And it's also, again, informing us of who's in the room. And so thank you guys so much. And I'll actually pass it to Rishi to go over the key DHCS guidance updates for us.
Yeah, thank you, Nasra. And picking up on Carlina's point as well, maybe I'll take a second as we go into the presentation for today. Again, to really just review some of the recent updated guidance from DHCS. I'll take a moment and see if there are any other questions, especially in the chat that people are flagging or in the Q&A about this. I also, Carrie Ann, thank you so much for your comment about the speed of our presentation. So we will slow our roll in terms of presenting. So thank you for that. And Carrie Ann as well, the technical parts of this. This is there are a lot of acronyms in the CalAIM process here. And so we'll pause and try to, where possible, clarify the terms as we introduce them. As Nasser mentioned as well, there's a link in the chat, and we'll provide this after today's presentation as well. You'll also, everybody who's registered will receive a link to the recording as well as a link to the slides, where you'll see a glossary of terms as well to get better oriented with the acronyms. There's plenty of them with CalAIM. So with that in mind here, please do welcome the questions and the answers in the chat. Any recommendations? Let's proceed to the next slide, please. I think maybe I'll go ahead and take the baton here. Give me one moment. Screen, tell me if you can see my screen now, please.
Yep.
All right, great. So we wanted to review some of the information that the DHCS had shared, Department of Healthcare Services had shared in an informational webinar that they had just a couple of weeks ago. This is guidance regarding, again, the latest updates to CalAIM, and specifically CalAIM ECM, which is Enhanced Care Management, one type of set of services that are supported under CalAIM, especially geared towards, for those who aren't familiar, Enhanced Care Management services are for those most complex, most high need patient populations or Medi-Cal beneficiary populations who often require complex care management. The community supports used to be called something else, which was in lieu of services. ILOS is a term that you may have heard, some of you may have heard about, but DHCS has since updated the branding for the in lieu of services, and they're now called community supports. Community supports relate to what DHCS has identified at least as 14 types of social or human services that have direct relevance to the health outcomes of Medi-Cal beneficiaries. Those can range from housing navigation services to asthma remediation services to medically tailored meals, respite care, et cetera. So when we speak about ECM or community supports, we're talking about those specific benefits under CalAIM, and these are all coming online as of January 1st, as many of you know. As we go into the updates, we're also, especially based on some of the responses to the polls about where people are at, because some of this language that we're introducing builds on some foundational information that has been shared previously by DHCS about what CalAIM is. We want to highlight a couple things before I proceed. One is we'll make sure at the end of today to provide links to some of the DHCS provided webinars. And I'll ask my colleagues to put some of those links in before the day is out so we can share those, including some of our implementation partners on the line. So we'll share some links to the DHCS information, like CalAIM 101 type of information. We'll also refer you to the first statewide session that we hosted, and we'll provide access to that recording as well, where we did some basic level setting on what CalAIM is as well. So please do know that if we do, as we go forward today, as we build on some foundational knowledge around CalAIM, if you still have questions about it, there are available resources online, and we'll do our best to direct you to those resources. What we do know is that CalAIM now, or DHCS, has provided some updated information on a variety of elements of CalAIM relevant to enhanced care management and community support services. This is relevant, we hope, for community-based organizations that are thinking about whether they are ready to or have the ability to provide these types of services for Medi-Cal beneficiaries. One of the updates is related to data exchange and reporting requirements. And so, again, we're taking information that DHCS had just recently displayed and trying to synthesize and communicate this for all of you on the line today, especially for your community-based organization. When it comes to data exchange and reporting information, DHCS and managed care plans all recognize that information sharing is essential. Managed care plans, or MCPs, counties, CBOs, or community-based organizations, and the state, DHCS, are going to continue to rely on, and will need to rely on efficient and effective information sharing to provide and coordinate enhanced care management and community support services. As you can see on the bottom here, we're trying to display the flow of information between the providers of enhanced care management, ECM, or community support services. Again, this is particularly relevant to if you're a community-based organization, a nonprofit in California that seeks to provide these services. As you can see on the left, information about members, Medi-Cal beneficiaries, members, residents, needs to be able to be shared, as you move to the right, with managed care plans. And of course, the managed care plans themselves, as you move further to the right, need to share the information with DHCS. As we go from the left to the right, there is various member level information that needs to be shared, of course, both from the community support providers and ECM providers to the plans, but also, as you see the return arrow, importantly, from plans to the providers. And this is particularly important because under CalAIM, for many CBOs that are not yet familiar with how this relationship will work, a lot of managed care plans will provide information directly to community support providers, or in this case, enhanced care management providers as well, to be able about members. So member information files will be shared so that providers, community support providers, enhanced care management providers know which members are being referred to them and which members they need to serve. There's also, besides member level information, there's additional information about billing, of course, other basic reporting information, and then that also has to be shared with the plans. We're going to focus more on this information today, the left-hand side of this graphic, this information sharing between providers and plans, and not spend as much time on another important dynamic to be aware of if you're a potential provider or community-based organization, and that's the information shared between plans in the middle and DHCS, the state, on the right. It's important to know, we're not going to focus on this today, but it's important to know that plans themselves have reporting requirements, information sharing requirements. And that means they'll have to submit information through quarterly reports to DHCS, provide data on the encounters that Medi-Cal members or beneficiaries have with community supports or enhanced care management providers, give information about providers themselves, and then information about outreach efforts as well, especially for enhanced care management. So as we go to the next slide, I'll take a moment to. I'm going to take a moment to pause before I go to the next slide, I should say, and just look at the Q&A and see how we're doing here. And look at the chat just to get a sense. And I'll invite my colleagues, Nasra and anybody else on the line as well on our team and our colleagues to let me know. Feel free to chime in if there's an important comment that's coming in that I need to address before I move on to the next slide. So thank you. But it looks like we've got couple comments coming in there. And so Shanaz, is this part of waiver programming or state initiatives? I think I know you're talking about. This is the CalAIM Transformational Initiative for Medi-Cal process. I'm gonna, and Carlina just provided some background information there. So thank you, Carlina, for that. So, thank you. So as we as we think about the guidance from DHCS, specifically around information sharing, again, the way it's relevant for CBOs in particular, it's important to note a couple of things. One, DHCS, as I've mentioned, has recently released several pieces of information related to information sharing. All the documents are available on the DHCS website for ECM, which is Enhanced Care Management, and Community Supports. We'll provide a link to that as well. You can also see the link in the PDF document that you'll receive for these slides. The guidance tracks along these 4 domains, as you see here. There's billing and reporting guidance. Sorry about that. There's billing and reporting guidance. There's member level information sharing guidance. There's quarterly implementation monitoring report guidance, which is more germane for the plans and what they need to provide to the state. And then really importantly for community-based organizations on the line today, there's also updated ECM and community support coding option guidance. Again, ECM being enhanced care management. There are elements here, again, this is getting into the technical because it is that type of program. There are a lot of technical aspects to this. As you can see for each domain, there are important elements of information that are germane for each of these bits of guidance. So for billing and reporting guidance, there are standard or minimum necessary data elements that plans will need to collect from enhanced care management or community support providers, particularly providers who are unable to submit claims using standard technical formats that other traditional clinical providers use to submit their claims to plans. If you're a community-based organization that seeks to provide enhanced care management or community support, and you don't have the capacity or haven't had the experience to submit claims directly to a managed care plan, it's important to know that there are some standard minimum necessary data elements that plans need to collect from you. For the member level information sharing guidance, there are standards, again, for data exchange. In particular, DHCS has provided information recently on the type of information sharing between plans and ECM providers, enhanced care management providers. That's important as well. For quarterly implementation monitoring report, again, this is relevant to what the plans need to submit to the state. Again, important to note that there are certain reporting requirements as well as a template, an Excel template that the plans need to submit. And then lastly, at the bottom, when it comes to the coding options, and Carlene, thank you again for putting in that information in the chat there. There are updated HCPCS codes, HCPCS. Now we're definitely getting to acronym city here. HCPCS is the healthcare, oh my goodness, coding, the healthcare coding, I need to remind myself here. These are standardized codes, I'll get the term, I'm blanking on it myself. So again, we'll ask for some help from my team.
Healthcare Common Procedure Coding System.
Thank you. Total blank there in the brain. So the HCPCS, I just called them by the acronym so much I've forgotten what they stand for. So the Healthcare Common Procedure Coding System. Thanks, Carlina. The HCPCS codes are used traditionally by clinical or medical providers who use these codes to be able to submit claims to plans. This coding system is generated by the Centers for Medicaid and Medicare Services, CMS, the federal payer for Medicare and Medicaid. So this comes directly from the federal government. And this is a collection of standardized codes that are often used to be able to communicate the information about what kinds of services are being provided. These codes are now being applied to enhanced care management and community supports. And the state, again, is providing updated guidance on what kinds of codes and modifiers to use if you're a community-based organization. So as we think about the flow of information, the data flows between providers on the bottom here in this graphic and plans going further up, and then finally to the state, you'll see that the flow of information, the flow of data that we're going to touch on today and that represents what DHCS recently updated relates to a couple different fields. First, there's information on billing and invoicing. This is, again, related to the kinds of service invoices that providers can provide to the plans or service the ways in which claims can be submitted to the plans. Again, these are using those codes, the HCPCS codes. There's member information sharing guidance. What DHCS has provided, I want to make a quick note, is that the guidance that DHCS has put out, the state has put out, is about information sharing requirements from providers, enhanced care management providers specifically, to the plans. This is, and then vice versa from the plans, you can see on the left here, from plans to the providers of ECM. DHCS has not yet released updated guidance about member information sharing for community supports providers to plans, but we imagine that that guidance will be coming in the near future. So I just wanted to make sure that everybody's aware of that distinction. The guidance that we'll be reviewing today on the member information sharing side, the information about members to share that DHCS has put out is relevant, that we're going to review today is relevant to ECM providers specifically. And again, guidance is not yet available specifically around community support to plan member sharing. So lastly, as I said at the top here, from plans to DHCS, there are quarterly reports and other data that the plans need to provide to the state. Again, we're going to focus in on this relationship at the bottom here between providers and plans. And as we go on to the next slide here, let's focus first on the billing and invoicing guidance that I just referred to. Again, some of the guidance that DHCS has put out is relevant to the flow of information from providers of enhanced care management and community supports to managed care plans. As I touched on earlier, providers, in this case, both enhanced care management and community support providers, are expected to submit claims using national standards. If they can't, which is likely to be the case for many of you, especially if you're not used to contracting and working directly with managed care plans, if you're unable to submit claims using these national technical standards, you can submit invoices. Providers can submit invoices. Plans and providers work together to determine the format of sharing that information of billing and invoicing. This is a particularly important point because at the county level, with the distribution that we have, the diversity of different plan coverage for Medi-Cal in each county, it's really key to be able to coordinate directly and reach out directly to the managed care plans in the counties that you seek to serve to understand the preferred format for sharing information and for invoicing in particular. The frequency of sharing, it's important to note for providers as well, the frequency of sharing information on billing and invoicing should be outlined in the contract language that you establish if you're going to do direct contracting with managed care plans. And that should largely be based on standard terms and conditions, will likely be based on standard terms and conditions that DHCS released several months ago. Again, we'll do our best to put the link into those standard terms and conditions if that's of interest to anybody. So this is the information again on the latest guidance from DHCS that again, you'll find links to in the chat about the flow of information about billing and invoicing from providers to managed care plans. When we think about the data elements in particular for billing and invoicing, we wanted to just synthesize some of the types of information in particular, because this is also an area of great complexity, especially for CBOs that are earlier in the journey of understanding the requirements for CalAIM and for managed care plan contracting. So first on the left, you see there's types of member information that's required to be shared. There's provider information about the provider itself. There's services and billing information, and there's administrative information. I'm going to present this briefly and then make space for Q&A so we can get into some of the specifics since we do have a bit more we want to be able to cover today. But the member information at a high level includes things like the NPI number, National Provider Identifier. If you do not know what an NPI is, during the Q&A, we can come back to this, and we have a few slides where we could explain both what the NPI stands for and how to apply for one. And we have that in this deck today that we can certainly pivot to during the Q&A. But information on about the NPI, the tax identification number for the provider, the billing information about the billing provider itself, taxpayer identification number, et cetera. On the services and billing side, there's primary payer identifiers that are required as well. The name of the payer, in this case, the plan counts of the unit counts. So if you're providing certain units of care, like number of medically tailored meals, for example, that information is important. Place of service, so where the service is provided, and especially for ECM providers, the types of diagnoses, et cetera. So there's a variety of information that's data elements, I should say, required for billing and invoicing. Again, we'll come back to this during the Q&A for those who have specific questions about those elements. Beyond billing and invoicing guidance, there's also information about member information sharing, as I mentioned earlier. So one of the important files or ways in which information is shared between the plans themselves to providers of enhanced care management, again, from plans to enhanced care management providers, the way information is shared largely comes through, most importantly, through a member information file, information about the particular members from the plans. The purpose of that file is to ensure that enhanced care management providers know about the members' clinical and non-clinical needs. There are certain required elements that plans need to submit monthly, and that is aside from member engagement information, which needs to be shared within 10 days of the assignment of a member to a provider. So plans will communicate both information about a member, but also information about newly assigned members, and that must be done within a short window of time. And yes, Denise, these slides will be shared following the call, as will a link to the recording of the call itself. So this is information that comes from the plans to the providers. The elements that need to be part of that information coming from the plans to the ECM providers include what you see on the screen here: a member engagement information, clinical information, as I mentioned here in the second column, primary care information about the member's primary care provider, and then administrative information. So information about the identifier for the plan, the phone number for the plan, et cetera, as well as the member record status information, as you can see on the right. One of the things we'll call your attention to, especially if you're a community-based organization that provides housing support or housing navigation or supportive housing of any sort, again, aligned with community supports, it's important to know that for at least the enhanced care management providers that are out there, the information that they'll receive, and that you, if you wanted to provide those housing related community supports, could utilize the information that you could utilize in that regard if you work with a local enhanced care management provider, is information not just on the left here about the name of a member, their address, et cetera, but also an indicator about homelessness. There's specific information that DHCS has provided about ways in which plans can signal to a ECM provider, enhanced care management provider, whether a member is likely to be or known to be homeless. And so that can show up in different ways in the data fields related to both address as well as using a specific indicator. So there's a lot of information, components of information that the plans need to send via member information files to enhanced care management providers. And there's also information that enhanced care management providers need to share, of course, with plans. So there's the provider return transmission file, which is a fancy way of, oh, and Lisa, thank you so much for joining. And we'll see if we can send you over the link for the panelists offline, Lisa, so you can join in on that. So if Nasra or Sam, my colleagues, can make Lisa a panelist for the call, that'd be really appreciated. So the information from the enhanced care management providers going to the plans can be communicated through a provider return transmission file. Again, the format and the frequency of sharing of this information should be agreed upon by the provider itself, the community-based organization that's serving as an enhanced care management provider, and the plan itself. And there are certain requirements of information, as you can see on the bottom here. There's member engagement information, there's the type of ECM services, specifically the number of encounters, and then of course, provider information about the ECM provider themselves. You'll see here under member engagement information, some things that are understandably kind of straightforward, or seem to be straightforward, right? In terms of the benefit start and end date for enhanced care management benefits. The status of member engagement, are they still in service? Have services been discontinued for whatever reason for this member? What's the name of the enhanced care management care manager? And are there recommendations for discontinuation for a member, and for what reason? So, go back on the slide here. As we think about the, there we go. As we look at, again, this information from the enhanced care management providers to the plans, there's some additional information that providers can and are expected to provide to many of the plans. This is one way is through the initial outreach tracker, the ECM provider initial outreach tracker. The purpose of this is to ensure that plans themselves have accurate information about the outreach that ECM providers are providing. And so there are a couple of methods for ECM providers to populate this outreach tracker. One is to use automated reports that essentially capture the information about their outreach. Again, the preferred method here is to do this in an automated way using the appropriate codes, the Healthcare Common Procedure Coding System codes, the HCPCS codes, But there's also opportunities, and again, this is important to converse with specific plans about in specific counties to confirm this, but there are also methods for populating the data manually. ECM providers will share this information with the plans on a frequency, again, agreed upon between the plan and the ECM provider. So again, here's yet another reason why it's important to take this, hopefully this helpful grounding information, this foundational information coming from DHCS, and be able to then communicate this directly with some of the plans that you seek to work with in the specific counties where you work. There's various data elements that are relevant here. The client identification number, I think we alluded to this earlier, the CIN, this is the client index number, excuse me. And so there's more information about that in the technical guidance from DHCS and other data elements you see here on the left in terms of outreach, date, and method. We're towards the tail, we're coming in the home stretch here in terms of information sharing, and you'll stop listening to me in a second so we can open up the field for additional questions. But one of the other elements that we wanted to highlight is another really important point, and something that we haven't seen come up a lot in our county specific sessions yet, but we wanted to bring up in this statewide session with all of you. And that's the potential for members to be referred, for individuals to be referred to become members, for Medi-Cal members to be referred for enhanced care management. So enhanced care management providers, and this is important for both if you're a potential ECM provider, as well as if you're a community support provider that works with enhanced care management providers, for example, with a federally qualified health center that might become an ECM provider. It's important if you're a community-based organization that provides medically tailored meals or asthma remediation or some other community support, to understand that there's potential for your partnering provider of enhanced care management, for example, a local clinic, community health center, for example, to be able to identify the plan members, Medi-Cal managed care plan members, who might be potentially eligible for enhanced care management services. So it's not just about the need to receive information from plans, but it's also, and to be able to provide those services, but also to be able to identify potential members that you can inform the plans about, members that you think might benefit from these additional types of benefits under CalAIM. This information through the potential ECM member referral file should be shared on a frequency agreed upon, again, by the MCP and provider. A broken record here on this point, but as you can see, there's a consistent theme in the DHCS guidance. And there are optional data elements that can be part of that member referral file. So wanted to mention that. Last but not least, when does this information sharing requirement kick in? And when does this new guidance kind of kick in? Well, like all things with CalAIM, we're only a few days away from launch, and that goes for implementation for data sharing in particular. The guidance from DHCS is that this should begin January 1st, but if that's not feasible, DHCS expects requirements for data sharing at least to be met by April 1st. So there's a little bit of a period of time after the formal launch of CalAIM on January 1st and April 1st, when, again, the state expects some of the data sharing requirements to kick in, especially the data sharing requirements that I just reviewed between plans and ECM providers. And lastly, just to reiterate, we'll likely see guidance. We may see guidance coming out about what information sharing needs to exist between community support providers and plans. And last but not least, information sharing guidance that may come out between community support providers and enhanced care management providers to each other, not just up to the plans. There are a variety of resources that I just reviewed kind of in a relatively fast clip, I hope not too fast. Some of the basic updates about that DHCS has submitted. We'll provide links, if we can, please, in the chat now over the next 5 to 10 minutes, including the links to these specific resources so you can click on them directly. And again, if you can't, you'll also be able to find these links in the PDF that we'll send out to everybody. But you'll see all the resources here. One of the important things to call out is that among the various bits of guidance that DHCS has put out, these updates, there's also on the bottom a public comment period open that's open until January 7th, related specifically to the CalAIM data sharing and authorization guidance. And so for those of you who want to look at that and want to offer some public comments, we want to make sure that you're aware of that opportunity. So Nasser, thank you for putting some of those slides in there. I'll turn it to you and we can maybe open it up and facilitate this Q&A. Maybe I'll start off by asking Lisa, who's joined us. Thank you, Lisa, as always, for your partnership from Transform Health. If you want to just introduce yourself, but also just to see if you had any additional clarifying comments, especially if I screwed anything up there.
Oh, you were phenomenal, Rishi. Hi, everybody. Lisa Chan-Son with Transform Health. Happy to be here with you all. We've been doing a lot of similar work here in Sacramento and as well as nationally, and it's really great to be here. We welcome any questions that you have. I know there's probably a lot of questions, and where we can, we'll provide as much clarity as possible. Many of you are probably thinking about implementation at this point, and it's worthwhile to note that, in where you are really does matter in terms of data sharing, because in some areas of the state, we have local regional health information exchanges, some which may or may not be able to support your data sharing. In some areas of the state, counties are considering putting together community or social health information exchanges. So understanding what's happening in your community and what current infrastructure exists really does matter. Where there are potential developments at play, where you might be in a community that's planning on building something, you may need a short-term data sharing strategy with your plan, and sometimes you may need a longer term, to bridge the gap until the longer term data sharing strategy can be put into place. So highly encourage everybody to talk to the county, talk to and look at what's available in your local ecosystem, as well as talk to your plan partners. Some plans are putting together and asking their providers to use a data platform where they're providing you the platform for sharing data and information back with them. And that varies plan by plan. So it's really important to have these conversations early to plan your strategy and figure out what you need in place in the short term as well as the long term. So Nasra, how would you like to facilitate the Q&A?
Perfect. And so if anyone would like to raise their hand, I can actually give them access to talk, or you can feel free to put your questions in the chat, or you can use the Q&A function and we can answer questions that way as well. And again, thank you so much, Lisa, for joining.
Happy to be here.
So maybe I'll, and Nathra, if it's okay, I'll just pick up on something that came up, kind of building on some stuff that came up earlier in the chat about in the poll responses. We saw, I think, a decent number of people who are from CBOs that are early in the process, early in contracting. And, given some of the very appropriate and valid questions about in the comments to say, wait, there's a lot of technical information here, there's a lot of details. I wanted to ask if we can maybe zoom out for a little bit to a higher level and just kind of review the value proposition of why this might be helpful, especially for CBOs that are early in the journey, that obviously provide really high value services to their clients, their beneficiaries. Why is this a potential benefit for them? What are some cautionary notes to take in this journey? So I wanted to just zoom back out a little bit, especially to attract to several of our attendees today who may have some more foundational questions before getting into the technical data sharing and DHCS guidance that I reviewed today. Lisa, I'll turn it over to you first, maybe to see what your thoughts are on that.
Sure. The Enhanced Care Management and Community Supports Program really represents a new opportunity for communities and CBOs within communities who are already serving really vulnerable populations across the state. And so when we look at this program, there's an opportunity to better serve those who are homeless or at risk of homelessness, or who are high utilizers. We're looking at, and thinking about how to better serve children and families, particularly foster youth, those who are reentering from stays in jails and prisons. We can do better. And the Enhanced Care Management and Community Supports Program represents an opportunity to do that. Our current delivery systems are really built for sick care. It's for when you get sick, you show up in the doctor's office, you show up in the emergency rooms, but it doesn't really have a way yet to understand how patients and families are really thriving while they're living in community. How are they doing within their homes? Are they able to manage their diabetes? Do they have stable housing? Can they feed their children? And so in a lot of ways, this program is about building out the rest of the delivery system so that we have a system of well care where we can monitor and understand how patients, families, children live, work, and play in community and how they're really truly thriving in community. So I'm really excited about this. I think there's a lot of opportunity here, but we also need to get the right players, the right organizations at the table. And many CBOs are those organizations that are the trusted messengers who are already providing these services.
Mm-hmm. Mm-hmm. Lisa, thank you. And I'm just, I see as you were talking, I think you're making wheels turn for a lot of folks right now. Joel, I see your question in the Q&A, so we'll come to that in a moment as well. And I saw, I think another question that came in or in the chat as well from Jeanette a little earlier. Do you have any feedback on how to connect with plans? We've done outreach showing interest in partnering, but there's a delay in responses at this time. Let me take a quick second just to share screen if I can, just to show the contact information for some of the plans that we've had the privilege of partnering with, again, in some of the initial counties where we've done deeper dive, regional intensive kind of TA sessions. So I'll share a screen just to show that contact information in a moment, and encourage anybody who's from a plan that's on the line today, whether you're going to be, you're from a plan that is engaged with some of our work directly right now or not, to go ahead and share your contact information too, to answer Jeanette's great question here. So let me share a screen really quick and show that. And then while I'm doing that, also, Lisa, maybe just ask you, and Nasra, please feel free to chime in as well. If you want to take on Jeanette's question first, then we can come to Joel's question next.
Sure thing. The plans are in the midst of transitioning and launching their HCPCS programs. So we know that there's a lot of activity happening. There's been, attention put to ensuring and transitioning beneficiaries from whole person care pilots. So a lot of the plans have, are trying to front load contracting with whole person care providers, given the state's encouragement. And, that really does make sense for continuity of care. But for all providers who are interested in connecting with plans, you should not be shy. And there might be some delays because of where they are in terms of building out their programming and contracting. But please know that we've heard from many plans. Most of them are going to be adding providers on a rolling basis on every quarter. Plans are allowed to add new providers on a quarterly basis with the state. And so we've already heard that there is interest in doing that. They just need to have to be able to take the incoming tranche of beneficiaries and patients first. And so they're pretty busy dealing with that. But you should, if you haven't seen it, many plans have a letter of interest where if you fill that out and get it to them, they'll respond back at some point with contracts with how, the package of information and how you can begin on the contracting process if you're interested in doing that. And so there's a couple of mechanisms that will support that. Don't be shy about reaching out to the plans and saying, hey, I want to be a provider. And is there an LOI? Is there a contracting application? What do I fill out first to get in the queue? And that's what you want to focus on, getting in the queue, getting on their radar. And, as plans work through programming and contracting, they will reach out to you and have conversations further, because we know that plans are building additional capacity over time on a rolling basis.
Lisa, thank you so much for that. I'm going to just go ahead and share screen here just to give some additional information on those, as I mentioned earlier, some of the plans, and really just want to do a +1 or an amen to your point about what we've learned from some of these great plan partners we've been working with, at least in the counties you see listed here. And that is that they're, as you rightly pointed out, as with across the state, many plans are right now by necessity focusing in on that transition of those in whole person care and health home programs to make sure that they experience a good transition into CalAIM as of January 1st. So I know that that's a very time intensive, onerous process that is a priority for a lot of the plans. So that may explain part of the reason for a delay from CBOs that are interested in partnering. But also, Lisa, your points, the several ones you mentioned in terms of how to make sure that CBOs understand that there are still opportunities, right, to be able to, don't give up if there is some of a delay. The email information over here is just for these plans, but you should know that every plan has contact information across all the counties if they're participating in CalAIM. So I'll stop sharing the screen there and just mention that. The other point, I think, let's go to Joel's question in the Q&A. And Joel, I'll encourage you to share that question if you want to just copy and paste that into the chat, because I think that we maybe as panelists can see your question. I'm not sure if everybody else can, but I imagine you might also get some really good responses from colleagues, especially in the nonprofit kind of CBO, community-based organization space to your question. I'll just read Joel's question out loud. Regarding the DHCS comment period for the data sharing guidance, which we alluded to, and again, that's open until January 7th. And Nasser, thank you again for putting that link in there. And thank you, Joel, for putting it in the chat. Joel says, I'm curious if there are some key criticisms and or recommendations for improving that guidance that are emerging from external stakeholders, i.e., stakeholders not including DHCS. It's a great question, Joel. It's something that I'll just say for HealthBegins, we're definitely keeping our ear open for that and trying to specifically over the past week in the context of some of the county specific sessions that we've been hosting. That's where we're able to get a sense of it. Some of the guidance from the HealthBegins perspective, at least it's so new. I think people are still digesting this as well. So I don't know if that might be an indication of why we haven't heard at least some of the key criticisms coming up, but I do want to invite you, Joel, if you have thoughts or questions, or just thoughtful concerns that you wanted to share from the perspective of some of the nonprofits that you work with or support. Feel free, please, to kind of share that here. I imagine that you're probably not alone among the other CBOs on the line. But I don't know if Lisa, so I have a non-answer, Joel, I guess, to that. We'll keep you posted. But Lisa, I don't know if you have a better answer for Joel than I did.
Yeah, I think that's right, Rishi. I think the guidance just dropped recently, and so there's a lot all across the state. There are a lot of organizations that are still digesting, thinking through, that practical applicability of that guidance. When we read it in the context of just thinking about some of the transitions from whole person care. One of the things that struck us was a lot of the guidance was very health heavy, particularly when it came to, sharing information around social determinants. And some things that might be useful is including housing status or last known location instead of an address, because not everybody may have a physical address. Those were some of the pivots that we had to make as part of our whole person care pilot up in Sacramento, when, we're really thinking through how to do the work. A couple of other things that might be useful, particularly when we're looking at those who are experiencing homelessness or at risk of homelessness, understanding that many of them are getting housed through public programs, understanding which public housing program they're in, and when the annual redetermination dates are occurring, because that's, some of the folks that you'll run across will need help getting through that redetermination. Otherwise, they may fall off their HUD-funded housing program, lose their housing voucher, and be put back right on the street. And then you're starting the housing work from scratch from day one again. So, there might be some, I would encourage everybody as you're reading through it, think about the context of the work And what information would you need to be successful in supporting patients and beneficiaries?
Thank you for that. And I think just to add on a little bit, and also want to thank our partner from Aurrera Health, Jill Donnelly. Thank you so much for sharing that information too, about the contact information that I shared earlier about all the managed care plans. Thank you for sharing that. And I think that's directly relevant to Jeanette's question that came up earlier. Joel, I see your reply here in the comments, so thanks very much. It seems like a tricky balance. I understand DHCS's need to track and have solid systems in place, and yet I'm concerned about the challenges some CBOs doing fantastic work and community may have in meeting some of the requirements, absent additional and potentially substantial investments and support. There's two comments that I wanted to kind of raise based on Joel, your great kind of reply there. One is that I think some of the concerns around the data sharing guidance will differ based on the type of community support and the type of enhanced care management provider. As the guidance itself identifies, there are issues or questions that may arise for those that provide behavioral health services. And when it comes, especially, Lisa, as you flagged earlier, for privacy concerns. And so I think there's an acknowledgement and at least an attempt in that guidance to walk through some use cases. So for those who haven't seen it yet, you'll see that there are some assumptions and use cases in there that include use cases related to behavioral health providers and how to navigate data sharing in the context of CalAIM, while also balancing out some of the specific and unique data sharing privacy standards for behavioral health. And so again, first point, Joel, and building at least on your point, is that some of the concerns will likely vary based on the type of enhanced care management and or community support that you provide and are unique to your particular type of service. So there is going to be some variety, I think, across the spectrum of community support providers and ECM providers. The second point is what you touched on, and I think rightly so, Joel, and this definitely does resonate with what we've seen, and I think same for Lisa and for our friends at Aurrera Health. And that's this question about the additional or potentially substantial investments and support required to do this work. Something that may help address that, and we hope will address that, is the two kind of tranches of funding. And I'm going to do my best to try to characterize these in a nutshell. And Lisa, I'll look for your help and answer as well to kind of add anything else to this. There are some dollars, there are some funds that may be helpful in providing some of the additional investments and support that CBOs in particular may be able to benefit from, that kind of additional investment and support, Joel, that you rightly flagged. One tranche of funding is that will go directly to the plans, our incentive payment dollars through the incentive payment program, again, because this is what we like to do with CalAIM. There are acronyms for it. So the IPP, the Incentive Payment Program, is a pool of incentive dollars that will also go online in a few weeks in terms of what's available for plans. And again, just as Lisa, you mentioned earlier, there's still a lot of focus on the transition right now of whole person care. And so I think even the plans themselves are still, to my sense right now, are still early in their process, or maybe not as far along in the process, probably is the best way to say it, in terms of how to just how to situate themselves to receive and then share those incentive payment dollars. But those incentive payments are meant to be, as the name implies, incentives, money that the plans can use to support and align ECM and community support services with identified quality or performance measures, to be able to provide incentives to help providers to be able to meet quality and performance measures for Medi-Cal beneficiaries. And so those dollars may be a potential tranche of funding, right, to support some of these additional investments in the infrastructure required for CBOs to do this work well. The separate tranche of funding that everybody in the state is waiting on, including the state itself, is the federal tranche of funding through what's called PATH. And again, I forget what the acronym is, but the PATH stands for something. It's a federal tranche of funding that the state is hoping to receive and negotiating right now with the federal government to receive, to be able to support, again, infrastructure. Now, plans, my understanding, Lisa, is that plans will not be able to access the PATH funds directly, but that those funds will be able to go to a variety of other stakeholders like counties and community-based organizations who can help support infrastructure development to be able to provide the technical assistance or at least opportunities for TA that might address some of the questions that Joel has about data sharing. I'll pause there and see if the IPP, the Incentive Payment Program, and the PATH funds are appropriate kind of categories of potential sources of funding Lisa, to answer Joel's question.
Absolutely. The IPP and PATH funds can be used for a number of different ways, including building shared infrastructure, local infrastructure, as well as building local program capacity and provider capacity. So, they can go to things like shared data exchange systems. It can also go towards helping a provider with their, like if they need to put in a system to support their ability for billing and invoicing, or like helping them build a staffing capacity, depending on the localized needs. So you're correct. In IPP, the plans were asked to, and they're going to be submitting next week their initial plan to the state around how they're envisioning and thinking about structuring that program and how providers might be able to interact with them to ask for funding. That's one piece. Then in PATH, there are 4 programs. One that goes to counties for transitioning whole person care and mitigating any effects of the transition into ECM and community supports. There's also 3 other funding. There's money that will go into a technical assistant hub that providers, counties, different stakeholders can access. There'll be dollars set aside for collaborative regional local planning. And then lastly, direct investment dollars to support infrastructure and capacity building. All 4 of those programs are within PATH. We're still waiting for CMS approval under an 1115 waiver. We don't know exactly the details of how those programs will be administered yet, but what we do know is plans will not be eligible for PATH, and they will, counties, providers will be eligible. And then separate and apart from those 2 important pieces, there's so much going on within our healthcare ecosystem. In the home and community-based alternative waivers, there will be some additional investment dollars that can go towards some of the shared investments around infrastructure. And under the behavioral health quality improvement program, there will be some dollars as well on the behavioral health side to address infrastructure and capacity. So we're expecting a number of these programs to come online, or more information to be shared next year. So definitely stay tuned, because there's going to be a lot of additional information coming out about how to access those dollars.
Thank you, Lisa, and thanks also to Joel and Carlina in the chat. Looks like the registration for the PATH webinar that was provided. Carolina, thank you for sharing that. Julie, you asked a question as well. Can plans deny partnering with particular CBOs? If yes, in what situation can they do this? And yeah, thanks for joining. I think at a high level, we'll probably take an answer to this. This is, the answer would be best answered by the plans themselves in the particular context. If you have a particular kind of situation in mind, I don't want to paint with too broad a brush here. But instead of, I think the frame that I would take is that instead of denying particular CBOs, the question is, as CBOs that have the potential to provide community supports or enhanced care management services, again, through either direct means or through intermediaries, which is another option that some CBOs may pursue if they believe that they don't have the bandwidth, the administrative kind of capacity to do direct contracting. They may still opt for intermediary kind of relationships to work with the plans. As CBOs who have that potential, who believe they have that potential to offer those services, explore that. And this is something, again, these statewide sessions and the local county sessions that we've been supporting, and we hope to continue next year to provide, addresses. As CBOs understand their readiness through these kinds of sessions, they then better understand the requirements that plans have to be able to enter into contracting. So it's not so much that there's I think as we've learned from some of the plans, that there is some sort of a black box approach where the CBO kind of blindly submits an application and waits for a denial. It really is meant to be a process, I think, as we've seen from all the plans that we've been working with, a process to a very measured kind of progress to go through and provide and to submit letters of interest, to go through a verification or vetting process, a credentialing process, and so on. And then sometimes in parallel to begin the contracting process, plans at each stage in that process will often signal whether there's alignment first and foremost with the needs that they've identified in their population and their counties. Again, that's captured largely through the model of care templates, Julie, but the plans also at each step of the way will likely signal whether there's when and whether there's a fit. When being an operative word there, because it may be that a plan still wants to stay engaged with the CBO, but recognizes that it's likely to more appropriate to onboard that CBO and those services at a later point in time because of the overall timing for CalAIM and all the moving pieces that Lisa referred to. Lisa, that's my best attempt at an answer to Julie's question. Did you want to correct anything there or add to that, please?
Yeah, I think another way to look at this is the plans are building a network of CBOs, like a social services network to wrap around their clinical network, right? So, each plan gets to choose which community support that they offer. And even within each category of community supports, there are a number of specific services, and your plan may or may not be covering every single service under that community support category. So it's really important to understand that, because that may be driving your plan to only contract with a certain type of CBO, because they're not going to be, bringing on that community support until 6 months down the road or a year down the road. So you'll want to also consider some of the timing too of this as well, and what community supports the plan is bringing on. Within a region, if there are more than one plan, they can be doing different community supports as well. So that's why it's important to have that conversation with the plans. And you'll know throughout those conversations, it'll become clear as you go through the letter of intent, go through credentialing, getting your NPI. You'll get a sense of the timing from the plans too, because if it's urgent and upfront, they're moving fast. But maybe it's something that's not going to come online till a year down the road, and so they're going to move a little slower on that piece.
I think we're at a good spot now to pause and maybe bring us home. The last comment I'll make, two comments. One is, as I turn it over to Nasra, back to you to kind of close us out. And Nasra, do you want me to share screen, or do you want to share screen?
Oh, perfect. Rishi, you can share screen.
Okay, I'll share screen. And as I do that, just two quick comments as I find my screen again. One is for the, where are we here? First, I wanted just to extend my thanks and our thanks, on behalf of Nasra and I, to Lisa, to you, to Carlina, of course, and everybody who participated. Jill from Aurrera Health participated in the kind of chat, and as importantly, to those of you who asked some of those questions and shared some information in the chat. So thank you for doing that. I'm going to go ahead and share a screen now and say one last thing, and that is that some of you, and I want to honor some folks like Joel who joined from RAMP, and thank you, Joel, for joining, and others. There are a variety of organizations that we knew about and are fans of and are partners with prior to this work, and then through this work, we've also recognized even more of great organizations in the state. The variety of TA opportunities that may be available if you're a CBO that's early in the journey and thinking about how to engage with plans to do this kind of work. You may already be aware of, but if you're not, please do know it's good to reach out to some of the community support specific networks that are emerging in the state, whether it's around, for example, housing support or asthma remediation or medically tailored meals. There are a variety of nonprofit technical assistance providers that have been there for a while and maybe a really invaluable resource for you as you think about how to do a deeper dive of understanding about your particular type of community support service, the alignment between your services and particular community support needs for plans. So we wanted to, I just wanted to make the point that this Partnership Development Network session, this last statewide session of this year for us, is only beneficial in the ability to connect people to people who are seeking technical assistance to the providers of TA, because we're not the only providers of TA here. Our mission collectively with Lisa and with Carlina and with our friends from Aurrera Health is to facilitate and expedite the ways in which seekers of technical assistance and the providers of technical assistance can meet more quickly to be able to improve the readiness to engage in the kind of meaningful partnerships that it'll take to improve the health and the equity for Medi-Cal beneficiaries in the state. So if you're a nonprofit provider, if you're a TA provider and you want to just share information, as Joel just did, do so now. That's an invitation for all of you to use the chat to be able to let people know the kind of work you do to support other CBOs that are out there. Having said that, let's go ahead and round us out here. So Nasser, I'll go ahead and present the screen here while you bring us home.
Perfect, and thank you all so much, and thank you, Rishi, for that. And for our next step, since this is our last session of the year, again, please reach out to us with any questions or feedback at info@healthbegins.org, and I'll also post that in the chat. Yeah, and can you move to the next slide for me, Rishi? And I also want to give a special thanks to obviously our HealthBegins team, Alexis, who isn't here with us today, Sadmi, who also isn't here with us today, and Rishi for being great and also just being able to provide this information with us. And also I would love to give a big thanks to Aurrera Health Group with Jill Donnelly and Lucy Pekel. And I would also love to give a big thanks to our funder, Carlina Hansen from CHCF, along with our implementation partners, Lisa, who is on the call, Gretchen, from Transform Health as well, Alex Fajardo from El Sol Neighborhood Educational Center, and Beth Siegel and Devin Whitney that are developmental evaluators. And of course, just a big thanks to all of you for all being here as well. And we will also be sending out that survey within 24 hours to you all for you guys to give a post-evaluation. And again, we'd like to thank you so much for attending.
I'll +1 that and that pitch for the survey. Please take the post-session evaluation survey. If you liked any minute of this presentation, it would mean a tremendous deal to us personally if you could do that before you go on your holidays. So thanks to everybody, Carlina, Lisa, Asra. Thanks everybody. Happy holidays, happy season, be well.
Thank you all so much.